Hey, so great. So it's good to be together with you all today, and I know we've talked about several different subjects in the past. Today, I kind of wanted to just talk to you a little bit about precision medicine, especially as it relates to HPB tumors, and I wanted to share with you work that's being done by my good friend Jason Siklik, who's at the University of California, San Diego. Dr. Siklik was just out here at Ohio State this past week talking about some of his research. And, I really think his research is going to be transformational on how we treat patients, not only with HPV cancers, but with patients with cancer in general. So I wanted to share with you his work today. And I want to be clear that this is all Dr. Siklik's work. And he's given me permission to share these slides with you. And these are his slides. But I just think it is such an important body of work that I'd love to share it with you and get it on your radar. So, really the whole conversation focuses around, personalized and precision medicine, right? So when we think of personalized medicine, it's trying to individualize a treatment for each patient when it comes to the drugs or the treatment strategies or maybe even the dosing. But really, precision medicine is that next step of really trying to customize the treatments based upon the actual molecular characteristic of patients' cancer. It tries to stratify patients, but it really doesn't individualize it. And I'll show you. Kind of precision medicine is this idea of like targeting a certain, mutation, for example, in ICC like IDH1 or FGFR2 receptor status. But what Jason's work, Dr. Sikler's work, really focuses on is making every patient an N of one. So every patient is their own control, and truly trying to move from precision medicine to what we want is personalized medicine. Now, currently, we tend to think of cancers this way based on anatomy and histology, right? We talk about I'm a specialist in liver cancer or pancreatic cancer, and focus, as I mentioned, really on site and histology. But in general, cancer is really anatomically and histologically agnostic, right? There are many tumors that share the same molecular profiles, but they may be very different when it comes to their histology or even their anatomic location. So we need to start to move away from classifying tumors based on their anatomy or even their histology, and really start to focus more and more on the genome and the epigenetics, right? And focus on different targetable mutations that unify patients regardless of their tissue diagnosis or their anatomic site. And we all know that genetic alterations lead to cancer by altering the genes and proteins and pathways, and it leads to cancers. But we have to realize that there's a lot of heterogeneity in tumors, right? There's heterogeneity in different tumors, pancreas versus liver versus colon, but there's even significant heterogeneity within certain classifications, like gastric cancer itself. And even within the tumor itself, there is heterogeneity in the cells, right? And here's an example of gastric cancer. And you can see where the tumor is located throughout the stomach somewhat dictates the genetic profiles. So treating gastric cancer as one disease is really going to be kind of erroneous thinking and not allow us to optimally personalize the treatment of patients, because we will have failed to recognize, realize, and target the different mutational profiles that can be quite heterogeneous within tumors and among tumors. So that's why we have to kind of move to more of this personalized approach that recognizes the intertumor heterogeneity within one cancer and even the clonal heterogeneity as tumors progress over time. So I think a perfect example of this heterogeneity is the way that we treat kind of biliary tract cancers, right? Very frequently, we think of cholangiocarcinoma, kind of as monolithically as one cancer. But we all know that ICC, gallbladder cancer, and extrahepatic cholangiocarcinoma are dramatically different. They're dramatically different in the way that they can appear histologically, whether they have sclerosing stroma or conventional stroma. They're different how they appear anatomically and present clinically. But despite this, we still treat all of these cancers relatively the same, right? With GEM-CIS-based chemotherapy protocols, and probably largely due to the effect of us treating them all the same way. The outcomes are pretty poor with, median survival only in the range of about a year. And so the question is, can we identify better approaches for treating and targeting patients with different types of cholangiocarcinoma, gallbladder cancer? And we know that biliary tract cancers are not the same, that there may be some overlapping in the different types of cancers, but there is probably more heterogeneity than there is homogeneity. And if you look at the specific targetable genetic alterations, they are very different whether the tumor is intrahepatic gallbladder or perihilar. And for example, you can see that intrahepatic, the IDH is mutated up to 30% of patients, whereas in gallbladder cancer, the HER2 new amplification is much more prevalent than it is in intrahepatic cholangiocarcinoma. So again, these tumors are not the same, and we need to become much more sophisticated in how we can potentially target the molecular heterogeneity of these tumors. And that's the shift away from just giving chemotherapy to everyone who has cholangiocarcinoma or gallbladder cancer, right? Treating everyone with GEM-CIS, right? We're trying to move to a more biomarker predicted approach to therapy for patients with these diseases. And this is this idea of targeted therapy, right? Where we target patients based on a specific disease marker, whether that be EGFR or BRCA2 with a platinum-based therapy or IDH1. And, you can see how this approach works is that, we try to identify a hotspot or a single genetic marker and then target it. And specifically for intrahepatic cholangiocarcinoma, there's been a lot of work in identifying the different genetic alterations with regards to this disease, whether it be FGFR2 or IDH1, or smaller subsets of patients who have BRAF mutations, and then targeting these genetic alterations. So these would be kind of like the so-called umbrella trials, right? One histology, different genes. So the histology being intrahepatic cholangiocarcinoma, but the different genes being, IDH1, FGFR, BRAF, et cetera. And if you look in the literature, one example of this would be the Clarity trial that looked at patients who had IDH1 mutations. These were patients who had histologically confirmed cholangiocarcinoma. They had centrally confirmed IDH1 mutations on next-generation sequencing, and they had measurable disease. These individuals were randomized in a 2-to-1 fashion to either placebo or isofenib, which targets IDH1. Crossover was permitted at radiographic disease progression, and the primary endpoint was progression-free survival. You can note in this trial, there was a progression-free survival benefit to isofenib for patients who had IDH1 mutation, with a roughly 60% reduction in the hazard of progression for patients who were treated with this targeted therapy. Of note, the disease control rate, which is defined as a stabilized disease or a response greater than 30%, was in the range of about 53%, which was significantly higher than in the placebo arm. And if you look at overall survival, you can see that there was also a survival benefit for targeting IDH1 with about a 50% risk reduction of death and about a 5-month benefit to targeted therapy after you adjusted for the crossover. So IDH1 therapy for IDH mutated cholangiocarcinoma is approved for patients as a targeted therapy with advanced disease. Another trial looks at FGFR2 fusions or rearrangements, and this is another example of trying to target one specific alteration. And in this trial, using sunitinib, patients who had FGFR2 fusions or rearrangements were given a sunitinib, and then the outcomes were disease progression and objective response. And in this trial, what you can see is that these patients were heavily pretreated. Over 50% had 2 or more lines of prior systemic chemotherapy. And in fact, a full 1/4 had 3 or more prior systemic chemotherapy regimens. And what is interesting to note that even in patients who had been heavily pretreated with prior chemotherapy, the objective response rate was still in the order of about 42%, with the disease control response rate of about 82%. And you can see that the median duration of the objective response was about 9.5 or 10 months. So I would say relatively striking data in patients with advanced cholangiocarcinoma who have been heavily pretreated with multiple lines of chemotherapy before, again, demonstrating the benefit of targeted therapy for patients with FGFR2 rearrangements or fusions. And again, showing the survival data here. And this was a single-arm trial, but again, showed a relatively good overall survival with targeted therapy with a 12-month overall survival of 73%. And again, because of these data and other data published on FGFR2 fusion-directed therapy, sunitinib and other agents have been approved for second-line therapy for patients with advanced cholangiocarcinoma who have FGFR alterations or fusions. Another type of study, unlike the umbrella study, is the basket trials. And the basket trials, instead of one histology with different genetic alterations, it's one gene and different histologies. So again, moving more towards this kind of histologic or anatomic agnosticism and really focusing more on the underlying genetic alteration. And here in this trial, the ROAR trial, this looked at patients who had BRAF V600E mutated tumors that was agnostic to where the tumor was located in the biliary tract. And in this trial, actually was agnostic to whether the tumor was in the biliary tract or other places in the body, whether it be thyroid cancer, or glioma, or a biliary tract cancer. And what you can see here is by targeting this BRAF, you can see the number of patients who had either a partial response or stable disease in the range of about 40 to 50%. Again, demonstrating that targeting a specific genetic alteration, regardless of the anatomic or histologic site, can be effective in a subset of patients. But as I stated from the beginning, these are kind of more precision targeted approaches, but really what we hope to achieve is a truly personalized treatment strategy. And that's not just cohorting patients into smaller groups based on a single mutation, but really looking at individual patients and their specific profile of their tumor, and then treating that patient, if you will, as an N of 1. So what do I mean by that? So that is using next generation sequencing to identify all of the relevant mutations at once that a patient may present with in their tumor, thereby allowing the opportunity not only to identify all the alterations, but also to target all of the alterations. And if you look at this precision targeted therapies, they tend to be effective in up to 30% of patients. But that means 70% of patients, it's not effective, right? Using a precision targeted approach. So what we want to really kind of move towards is, a personalized approach that's molecularly guided. And if you look here in this NIH trial in 2015 that looked at molecularly profiling tumors and then trying to target those agents in this Shiva trial, you can see that it was not statistically significant. But what was interesting is that 40% of patients had more than one molecular alteration, but they were only matched or treated for, one of those alterations, and there was no difference in their overall survival. So now more recently to Dr. Cyclic work, this is this notion that instead of just targeting one of the alterations, is it possible to target all of the identified alterations? So in this study by Dr. Cyclic and his colleague, Dr. Kurzrock, they identified patients with serious lethal malignancies who are anticipated to have a 2-year mortality of greater than 50%. They did next generation sequencing using a number of different platforms, as you can see here, and then attempted to target all potential or as many possible molecular pathways as feasible using truly customized combinations. So this is, again, this idea of each patient is an N of 1, and each snowflake is different. And by identifying the cogenetic alterations and targeting all the alterations, that patients may have better outcomes. So again, this idea of an N of 1 is that patient 1, they may have 3 different markers. So you use 3 different regimens that specifically target their molecular alterations, and that may be different from patient 2, who has different markers that you target. So really customization. And why is this important? Because most tumors, as I noted, are heterogeneous. There's spatial heterogeneity. So that means that over time, different clones in the tumor spatial heterogeneity means that different tumors in different locations can have different molecular profiles. And then there's temporal heterogeneity, which means that over time, with the progression of the disease, that there may be natural pressures that lead to variations in the molecular profile of the tumor over time. And what's interesting to note is if you look at most patients, and in this study of Dr. Cyclic's that they published in Nature Medicine, if you look at the different tumor types, of which gastrointestinal hepatobiliary represented about 40% of patients, the median numbers of prior therapy was 2. But what was even more interesting to me is that the median number of genomic alterations was 5, right? So this again is this idea that if you just target one of those alterations, it is unlikely that you are going to have a durable or even significant response, because most patients have multiple different genomic alterations at the same time in different pathways, as you can see here on this pie chart. So their idea is to come up with this matching score. So it identifies the alterations, and then they try to target all the alterations based on a very kind of tailored, specific chemotherapeutic regimen. And so, for example, here's a patient that presented who had a large tumor in the liver, a gallbladder cancer. And typically this patient would be treated with Gem-Cis, but they identified a BRCA2, a PIK3R1 splice, and then also another PTEN variant. And they treated this patient with cisplatin, carboplatin, everolimus all at once, which I would say is not like a typical regimen that we would use for gallbladder cancer. But you can see that this patient had a 3/3 100% matching score, and they had significant downsizing of their tumor and improvement in their progression-free survival. So what this study involves is that patients who had more than one prior treatment, who had advanced disease, they are consented, and then they undergo comprehensive genomic profiling. And if there is no alteration identified, they're treated standard of care according to what the physician would like. If there's an alteration that is identified, then they're sent to a molecular tumor board where they identify the different genetic alterations and then different drugs that could particularly target those alterations. And then they recommend that to the treating physician. Now, the treating physician could do what they like. They could choose to accept that regimen, or they could not. But that is what they recommend. And what's interesting is that if you look at the matching score, if you have greater than 50% matching, so you matched a therapy with more than half of the genetic alterations that were identified, you can see that progression-free survival, a partial response or a complete response was significantly higher in that cohort of patients than it was in patients who did not have a high matching score. So this high matching score translated into significantly better objective response rate and progression-free survival. And what's interesting is that typically we think with second-line regimen, or third-line regimens, progression-free survival gets shorter, right? Because it's less effective therapy. Usually, you treat someone, they have the longest progression-free survival. You move to second-line therapy. Usually they progress pretty quickly on second-line therapy. Third-line therapy, they progress even faster. But what's interesting in Dr. Sicklick's study is that when patients were treated with the recommendation for the molecular tumor board and they had a high matching score, you can see that their progression-free survival second line was actually longer than first line, which is actually pretty surprising and amazing. And this translated into better progression-free survival and overall survival, as you can see here, matching score greater than 50, 60% hazard reduction in probability of progression-free survival, and again, about a 50 to 60% reduction in overall risk of death. So here's a couple other examples. This is a patient at a stage 4 intrahepatic cholangiocarcinoma, underwent next-gen sequencing, KRAS, MLH1, TP53 mutations. And this patient was sent to molecular tumor board and then recommended to get trametinib and nivo. And you can see here that the patient had a pretty dramatic response. And not only was the response pretty dramatic, it was fairly durable. At 52 weeks, you can see here that significant reduction in size on cross-sectional imaging based on RECIST criteria, and then also a marked reduction in their tumor markers from 8,000 to 10,000 down to 20, and again, pretty durable out 60, 70 weeks. Here's another patient with hepatobiliary tumor that had BRCA2, PK3, and a P10 mutation. This patient was treated with carbo and everolimus. This is the patient that I showed you earlier. And you can see again, on week 8, only 2 months after therapy began, a pretty dramatic response in the liver. And then this is a patient with pancreatic cancer with a KRAS, ERBB2, and a CDK mutation. And this patient was treated with trastuzumab, lapatinib, and trametinib. And you can see that this targeted multiple different genetic alterations. And also what's important is it treated things kind of like upstream and downstream in the pathway. This patient had a pretty dramatic response. You can see these things are FDG avid, and after a week of therapy, several of the lesions are no longer FDG avid, and the other 2 are smaller in size and slightly less FDG avid. So, it brings us to this notion that next generation sequencing can and should be used in today's clinical practice to really identify things that are targetable. And when we think of multidisciplinary tumor boards, traditionally we've thought of like a radiologist, a pathologist, medical oncologist, and surgical oncologist. But I really think we need to start incorporating kind of artificial intelligence and molecular information into our discussions of our multidisciplinary tumor boards. And again, highlighting the importance of bioinformatics and molecular biology and considering the recommendations that come out of these groups. So really, MTBs can improve the delivery of more precise targeted options. Patients who undergo molecular profiling, they should be identified for clinical trials, and then they should receive more precise molecularly targeted therapy. And if you look at some of the data from Dr. Siklik's research group, looking at real world data out of these molecular tumor boards, you can see here that in patients who were seen by their molecular tumor board, so about 715 patients with a wide array of different types of cancers, that again, higher matching scores consistently resulted in better outcomes, with almost 1 in 5 patients either having a complete remission or partial remission if you can target more than half of the identifiable genetic alterations on next generation sequencing. And again, this translated into a pretty significant survival benefit with a risk reduction of death of about 40%. And if you can see, if all recommended medications were used, that had the best effect compared to partially adopting the recommendations or just kind of winging it, which is what most of us do now, right? We say gallbladder cancer, GEM-CIS, and we're just kind of treating everyone the same. You can see that there's a lot of opportunity that we're living on the table if we do not approach things in a more kind of nuanced molecular approach. So all of this is kind of talking about using molecular therapy as second-line therapy, a third-line therapy. But there is this notion now that Dr. Siklik has been talking about, is that, can we even improve the disease controls even more by moving this targeted approach up, to first-line therapy, right? Because we talked about tumor temporal heterogeneity and kind of genetic drift over time. But perhaps should patients have molecular profiling of their tumor when they present and not waste time, so to speak, on GEM-CIS or, what nab-paclitaxel, but kind of immediately, profile these patients, send them to molecular tumor board and target all of these pathways at once. And this is kind of ongoing work that Dr. Siklik and his colleague, Dr. Kurzak, are beginning now, which I think will be extremely interesting to see, and again, potentially be paradigm shifting in how we treat patients. And if you look here, as far as the treatment naive and the molecular pathway targeted patients, you again can see that in some preliminary data, this notion that, even patients who are treatment naive, the number of genetic alterations per patient is still in the range of 5 and some as high as 15. So it's somewhat naive to think that treating patients with, GEM or even full Furanox or some of these agents is really going to have a marked and or durable effect if we're leaving other genetic alterations unaddressed. And so, again, these are some of the preliminary data from the iPredict using matching for patients who initially present before they undergo traditional systemic chemotherapy, again, showing a pretty dramatic benefit from using a more nuanced, targeted, personalized approach. So overall, I think the lessons learned is that, DNA, RNA, immunohistochemical staining is all incredibly important, and we need to collect this information earlier rather than later. Single agent therapy, so-called, even precision medicine will often be inadequate, because if we are trying to be precise by only targeting one pathway, the tumor is smarter than that, right? And there's more pathways that are mutated. And so really, I think, Dr. Siklik's work points to the fact that we need to move towards molecular tumor boards that integrate all of the genetic information, look at all the genetic alterations that are at play, and then try to combine genomically targeted therapies, immunotherapies that come up with a truly personalized approach for that specific patient. And we didn't talk about it a lot here, but I think the other thing that Dr. Sicklick's data demonstrates is that this can be done safely. There was a lot of concern, and he talks about this, how the IRB had a lot of consternation, concern about mixing and matching different drugs that were traditionally not used with one another. And they did this in a very, very safe manner, starting off with about like half the dose of many of these drugs and then incrementally increasing the dose to make sure that there was no toxicity. And as he noted, this therapy was actually tolerated fairly well. And so collectively, I think his body of work points towards a more personalized precision approach that not only will probably be applicable for later stages, second and third line therapy, but I think in the future will be more utilized for earlier stage disease and frontline therapy. And so, you know, the era of precision personalized medicine is upon us. And as surgeons, if anything, I think that this approach will probably broaden the indications of surgery, similar to how advancements in systemic therapy for colorectal liver metastasis kind of broadened the definition of what was resectable for that disease. I think as we have a better understanding of precision and a personalized approach to some of these other aggressive tumors, we'll probably be moving in combination to a personalized medicine approach to more surgical approaches about debulking tumors, removing, you know, resistant clonal disease to prolong a patient's life. So again, I want to just again recognize Dr. Sicklick, who is a surgeon. So it's important to note that, you know, Dr. Sicklick is a surgeon scientist and is really at the forefront of all this work. And I want to thank him for the opportunity to share his work and his slides with you today. And with that, I'll conclude. And Hisham, I want to thank you and your colleagues again for letting me join you today and chat with you about what I think is really important work. Thanks.
Thank you for the very interesting talk. I'd like, if any of the audience has any question, please raise your hand. I start with a question myself. When do you see this integrated into our daily practice, or do you see this translated into a daily routine anytime soon?
I do. I mean, I think it's obviously going to be different, maybe, you know, based on what resources are available at any given like hospital or clinic worldwide. But, you know, here at Ohio State, you know, we're molecularly profiling, you know, everyone's tumor. You know, I think we've talked about this before, even for intrahepatic cholangiocarcinoma, given that the incidence of recurrence is high even after curative intent therapy. These patients are going to need, you know, first and second line therapy. So we need to get this molecular information as early as possible. Right now, there is a national trial that Dr. Sicklick is leading with multiple centers in the United States that is actively looking at what I just talked about you in a multi-center setting. And I think, you know, once those data bear out what they have seen at UC San Diego, I personally believe that this is where we're headed. It never made sense to me, like, why are we waiting, right? I mean, it's such a simple notion that he came up with. Identify all the target, you know, all the genetic alterations, target all the alterations, right? Like, why do we think just like targeting one pathway is going to work? It ain't. And why do you think like targeting them serially one after one another is a good idea instead of like, you know, boom, you know, hitting it all at once?
Okay, Dr. Medhat Khafaga.
Thank you, Dr. Pawlik. My question is it time now to use this targeted therapy in the new adjuvant setting?
Yeah, that's a good question. I don't think right now, like, this is ready for like neoadjuvant setting. If someone's like clearly operable, then, I think still standard of care would be to like, at least for cholangiocarcinoma intrahepatic, I think you could just take it out still, right? There's no good data to say. I think for patients who have like borderline disease where you're looking for a response that could potentially make them resectable, I think this is very appealing. So more like conversion chemotherapy, right? Because you saw that in some of these patients, they have pretty dramatic cytoreduction of their disease. So perhaps by adopting this approach, we could take someone who has a large burden of disease that may be inoperable, shrink their disease and make them operable.
How about can we start any study for using them as an adjuvant after surgery to increase the survival of these patients?
Yeah, I think that's what they're looking at right now, is looking at this iPredict approach for people who are like chemo naive. So the first trial looked at patients who had, very poor prognosis, less than 50% 2-year survival, second line therapy, because people were very nervous, rightly so, about using different agents that traditionally have been not used with one another, and then using like multiple chemotherapeutic agents simultaneously and the toxicity. But I think the first iPredict trial, demonstrated that this could be done safely with minimal toxicity. And now I think because of both the efficacy data and the safety data, now they are looking at, as you mentioned, using it as like first line therapy. But still, it's for patients with advanced disease. It's not really for like adjuvant. If someone has no measurable disease, I'm not sure like this is, we're not quite there yet, right? I don't know if I treat someone with like 3 or 4 different chemotherapeutic agents and they don't have measurable disease and you're just basing it on like liquid biopsy. I don't think that's what we're suggesting right now.
Thank you.
Yeah, you bet.
Okay, any other questions? Please, if anyone has a question, raise your hand. Dr. Mustafa.
Yes. First of all, thanks for this informative lecture. Please, what's your opinion about use of neoadjuvant chemotherapy for operable pancreatic cancer?
You say that one more time? For what? Neoadjuvant?
Your
or
opinion about neoadjuvant chemotherapy for operable pancreatic cancer, resectable pancreatic cancer.
Yeah, I use neoadjuvant for everyone. For everyone who has pancreas cancer, even if it's operable, I treat
Oh.
patients with upfront neoadjuvant. Is that your
For
question?
yes,
Yeah, everybody. And
everybody fit and small
everybody.
lesion.
Doesn't matter how fit they are. Because pancreas, I think the data would suggest that in the majority of patients, it's a systemic disease at the time of diagnosis. I mean, I think there's some good data that was published by like Steve Leach and others to show that. So I don't really see the downside of giving, preoperative chemotherapy to patients because they're going to need chemotherapy anyways. So I might as well give it beforehand. And if they develop a liver metastasis while they're getting chemotherapy, they avoided an operation that never was going to help them in the first place because that liver metastasis was there when you started the chemotherapy and it grew through the chemotherapy. So, in general, I heavily favor preoperative chemotherapy, even for operable disease. Do I think it's wrong not to use it? No. I mean, if patients feel adamantly that they don't want it, I'd still operate on them, but I would try to discuss with them why I think preoperative chemotherapy makes sense.
Because follow-up to response in pancreatic cancer is difficult.
Yeah, I'm not looking for a response though, right? If it's operable, it's operable, right? I don't need a response because it's operable, right? What I'm looking
But
for
it
is
may be progress during this period.
I'm looking for biology. It's unlikely that someone's going to have locally progressive disease after 3 months of chemotherapy, right? But the chances of developing metastatic disease is actually not inconsequential. So it's a test of biology. you know, to make
Thanks
sure.
a lot.
Yeah.
Okay, any other questions? Last chance to ask a question for Dr. Pawlik. Okay, guys, that was it. Thank you, Dr.
Okay,
Pawlik,
everybody. Yeah, thanks for joining me. Have a great day.
and see you in Egypt soon.
All right.
Bye-
See you soon. Bye,
Bye-bye.
everyone. Thank you. Bye-bye.
Bye. Bye.